Jay, about doing
Yeah, just about. Got a little bit more to go.
all right. Got it.
Line 111, what's the address of your emergency?
It's 2131 Apple Road.
Give me that address again for verification.
2131 Apple Road.
What's the phone number you're calling from?
It's 910-612-1150.
And give me that phone number again for verification.
910-612-1150.
Okay, tell me exactly what happened.
They were working out on the electrical machine and just kind of fell out when the chest hurt.
All right, are you with the patient right now?
Yes.
How old is he?
He's 65.
Is he awake?
No.
Is he breathing?
No.
Okay, stand in line until the paramedics can help you right now. I'm going to tell you exactly what to do next.
Okay.
Is there a defibrillator available?
No, not.
Okay, your right line right now?
Yes.
All right, I want you to lay flat on the back on the ground. Remembering the pillow. Okay. Now place your hand on his forehead and your other hand under his neck. Okay. Put your ear next to his mouth. Feel the ear and breathe.
No.
Okay. I'm going to tell you how to do chest compressions now. Listen carefully. Make sure he's flat on his back on the ground.
Okay.
Place the heel of your hand on the breastbone in the center of the chest, right between the nipples.
Okay.
Put your other hand on top of that hand.
Okay.
All right. I want you to pump the chest hard and fast, at least twice per second, and 2 inches deep. All right.
Right now?
Let the chest come all the way out between pumps. We're going to do this 600 times until help can take over.
Okay.
I want you to count out loud so I can count with you.
Okay. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30, 31, 32, 33, 34.
All right, you're doing a great job. I just want you to keep on doing this. This is going to keep it going until paramedics can get there. Keep pumping.
41, 42, 43, 44, 45, 46, 47, 48, 49, 50, 51, 52, 53, 54, 55, 56, 57, 58, 59, 60, 61, 62, 63, 64, 65, 66, 67, 68, 69, 70, 71, 72.
All right, you're doing a great job. We got firefighters and paramedics on the way.
75, 76,
Just tell me when they get there.
78, 79, 80, 81, 82, 83, 84, 85, 86, 87, 88, 89, 90, 91, 92, 93, 94, 95, 96, 97, 98, 99, 100, 101, 102, 103, 104, 105, 106, 107, 108, 109, 110, 111, 112, 113, 114, 115, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27. Come in. Sir, the fireballs here. Come in.
All right, firefighters here. Firefighters take over. You're doing a great job. Thank you.
Sir, step away. I got 2 guys that's going to take her. He just fell out. I got 2 guys that take her CPR for you. He just fell out. Right. I mean, that's your dumb question. He needs help. Okay. What was he doing when he went to start that arrest? He was running on this, and he just fell out before. Okay. Did you? Was it a witness arrest? Yes. Okay. How long have you been performing CPR? I got up to 120 or 130 chest pressure. Okay. You know his medical history? Yeah, he's got high blood pressure. He's got heart issues. Takes all kinds of medications for all that kind of stuff. Okay. Is he allergic to any medications? No, nothing I'm aware of. Okay. I need for you to go get his medications and bring him right back to me. All right. Hurry up, sir. Thank you. Heart conditions, not allergic to the medication. Any question there? All clear? Hey, here's some medication and stuff. What's going on with that? I'm taking it to the hospital yet. No, we good.
Just go wait for your
All right. Right. You got a 65-year-old female who's on the exercise body. The witness cardiac arrest.
What's going on with that, guys? I can be on to the hospital yet. He needs to go to the hospital. He needs the doctors.
We're on the second round.
He needs doctors right now. I can be on to the hospital. Come on.
Second round from the fire department. Come around from the hospital before we arrive.
Why are you on that? Why are you taking him to the hospital? Hey, sir. Sir, what's your name? It's Billy. Billy, I'm Dan. How you doing? Good. How come you guys are taking my dad to the hospital? They're doing everything that they can. He needs doctors. He don't need fire. He's in a fire.
All right, should be too much.
Yes, sir. Here, and he was working out, and then kind of fell out. Yeah, and then he just fell out. I told him, all right, did a great thing, man, doing this crisis. Did a great thing. What they're doing right now, is everything that we're doing for your dad right now. This is the best thing for your dad. See the compressions that are going on right now? Yes. Breathe as hard as we can to turn that heart back on. We're going to do everything that we can do for your dad. What I need you to do is call Shannon. I need you to call a friend. A friend that's close by that can come here. Can you do that? Okay. Go ahead and sit outside. I'll make those phone calls. I'll be right with you. Aaron, what do you got? 2 shots. 2 shots. 150. Any drugs? Any drugs? 1 epi? Be fit all the time? Yes. Fire department shot? Yes. 175. Everybody's good?
Yes.
200.
I was like, rhythm.
third shot here? Okay. Is there anything different?
We're gonna start out hangover.
All right. 300 hangover. All right. I'm gonna check with Billy, okay? Hey, Billy.
Good, guys.
How's everything going, Billy? You made those phone calls?
Yeah, I called my mom.
Called your mom?
My buddy Jimmy, he's gonna come here and, what about you guys?
Okay, bro, they're still working it out. Okay, so how far away is everybody? Just a minute. Okay, perfect. And he's on his way here right now? All right, okay, like I said, they're doing everything that they can for your dad right now, okay? So we're gonna walk back in there, all right, we're gonna support what we're doing, okay? We're gonna go over there and watch the work being done to your dad, okay? All right, come on. Can you check in with your mom?
Yeah, she's one of the biggest.
All right. How are we doing there? Anything else? Okay. He's still good? All right. You did have a cardiac history?
Yes.
Problem with his heart ever?
Yeah, he's already got high blood pressure, mutation, it takes some time off.
All right. So you have any medicines?
Yeah, they're,
You feel really good right now?
no, I'm not sure that.
All right. Hey, take a look over here, Billy. Look at that monitor there. You see that squiggly line there? Yeah, that means that his dad's heart is literally just sitting there shaking. And we're introducing electrical current into the heart. Trying to get it back. Okay.
Saving.
We're doing everything that we can right now. That's a chance. We're doing right now. This team. Okay. All right. You said your buddy was going to be here in a few minutes?
Yeah.
All right. Can you go stand by the door for a minute?
Yeah.
If we need anything, we'll get you, all right? No shot. Billy, is he here yet? He just pulled it. Okay, all right. Okay, let's go up to the doorway there, all right? Okay. Your dad's still in here, okay? We're still doing everything that we can. All right, all right. You're gonna draw it, baby? You're gonna give me the other? So you wanna hold that back? Some comes back on the hand. Back on. 150. Captain Arthur rising up there from here?
Yes, straight.
35. Right pulse?
Yes, sir. Looks like mine is stacked.
All right.
I'm the same.
He's at the door right now watching with his buddy. I'm gonna go over there and give him an update.
I'll have totally here in a minute.
All right, you get your pressure. All right. Hey, Billy.
Yes, sir.
All right, so you got your buddy here?
Yes,
What's
yes.
his name here?
Yes.
Hey, Jim. I'm David. You're Andrew. Nice to meet you. Hey, so listen here. What I need you to do is I need you to drive Billy out to the hospital, okay? I really, really encourage you to go with your buddy, okay? All these people that you see here are going to be going in that ambulance. As you can imagine, it's going to be cramped, okay? But right now, he's got a full back. All right? They're doing some things. Yep, they're doing some things right now. And they're going to stabilize him. They're going to get him on the all right, so beat us up there. All right, done a great job. All right. We need there?
We have Ross.
Ross,
This is Stevie.
Stevie.
12 lead.
12 lead.
Watch your truck. Let's start going to space.
All right, we'll get your fluid call and you'll get it. You get a good pressure. What was the pressure?
9
fluid, and where you're coming in, and they've activated the send. Tight fit in these houses. Hello everybody, my name is David Glendenning. I'm the Education Field Training Officer with New Hampshire Regional EMS. Welcome, thank you for coming to this lunch. Thank you, Race Cars, for allowing us to be a part of this wonderful gathering of great people, influential people, people that are here to change cardiac arrest and cardiac care and all the things that come with it. We're going to start off with trivia. I know you guys are working on your lunch. Everybody loves trivia. So some of you will know this answer right off the bat. Some of you may not know this answer. Where would you want to collapse and go into ventricular fibrillation in the United States? Where are you going to have the best chance? Right here, right on the stage. Where? Yeah. How about a place where there's a dedicated amount of training responders? How about a confined environment? Confined environment. Okay, it starts to get a little more close now. Numerous security cameras. Now we're thinking government. No, not in government. The AEDs are there.
Go here.
Your average time if you collapse the shock here will be 4.4 minutes. A casino in Vegas, winner! Very good, yes. Those of you that work the slot machines or have significant others that do, don't worry. They're in good hands if they hit the big one. Well, maybe you didn't want to share the money. But yeah, you have a 74% chance that you're going to get discharged out of the hospital if you collapse and refib in a casino. So you are in good hands. We need to always look back at history. History is where we come from, and this is where we learn how to do things. Don't you laugh? They thought this was correct back then. And yes, we are trying to do compressions in some way, some form here. By pushing via the flank area. He doesn't have any kidney stones. And as you can see on there, he has some type of ventilator. That's called a pulmotor. That's called a pulmotor. Back in the days when somebody would arrest inside the hospital, they would call the fire department and say, "Can you bring that breathing machine up here?" They had somebody that wanted the cardiac arrest on the table again. So they would wait for the fire department to respond, and they would bring up this device, and they would ventilate the patient for them. Yes. So we thought back then that that was the way to do it. CPR hasn't been around that long. We can flash forward all the way up to this moment in the 1950s and 1960s. Exactly. There are a lot of gentlemen involved, however, there are thousands throughout history dating all the way back to the Bible that should get credit for cardiopulmonary resuscitation. Back in the 1600s, the 1700s, the 1800s, we came up with the right way to do this. However, everybody had a great idea, they think that it would work, and then we could find a way, and we didn't have the internet, we only had word of mouth. Stuff just didn't get shared like it did, so it would disappear, and somebody else would bring it out of that drawer 20 years later and maybe dust off the name and take credit for it. And on and on and on. There was a time when we thought ventilations from another human were bad. We had mouth-to-mouth for a while, then somebody came along and said, "No, that's bad." So then we quit doing that. We all know that that's not true today, right? These gentlemen here, to your left, worked diligently in Johns Hopkins, and they were employed by Edison Electric. They were trying to figure out a way to bring people back who were shot on the line. So their work was to come up with a counter shock. They didn't really know exactly what they were doing specifically, but they had the work was to come up with a counter shock that would hopefully bring them back to life. So one day in the lab, they were applying these paddles onto the chest of a dog. And they were heavy, cumbersome paddles. And they looked and they realized, okay, output. They saw some carotid reaction. So they went to an actual practicing physician inside St. John's and told us. He said, "You know, if we push on the outside of the chest, we might be able to do something here." Really? Brilliant! Compressions were back on the table, and compressions on the outside. Back then, the only way that you were going to survive compression-wise was if you happened to have a heart that was exposed, i.e. surgery, or you were in a hospital where you could cut your chest open right away and do massage. You have a really good chance of not with that, or coming out of the hospital. So these folks on the left came up with compression. They also came up with defibrillation. If you think about it, they were working. And the gentleman to the right, Dr. Peter Safford, via the Pittsburgh area, This is the breathing guru here. This is the father of RSI. This is the father of airway management. The gentleman right here, if I get this pointer to go right there, Chief McMahon, the Baltimore Fire Department, was in this environment here to the right, and it happened to actually be working with the gentleman on the left. And lo and behold, he had a conversation between the two, and it's rumored that he said, hey, if you add this to this, that might be a good idea. Boom, they said brilliant. They trained the Baltimore Fire Department in some of these techniques, and CPR was born in 1960. However, it was also born in EMS, if you think about it. The problem was, those brilliant gentlemen said, nobody other than a doctor can execute this. CPR is far too important for anybody healthcare-wise except us physicians to do. This gentleman right here disagreed, Dr. Claude Beck from the Cleveland area. He said, no. We can train healthcare providers, we can train layperson. Let's get this on the road. It can't be just for physicians. So he organized in 1961 the first layperson concept for CPR. He also realized that buy-in on this, seeing survivors actually standing forward and giving testimony, would win support. People want to learn how to do these techniques. So he got into the movie industry. And his colleagues out in Seattle saw this and said, this is a great idea. We're going to take this even further. And in 1970, Seattle battled back. They trained 100,000 citizens in full CPR in 2 years. Taught 911 dispatchers how to give BLS direction over the telephone, kind of what you saw here today. And they intensively trained paramedics to work in synergy with the first responders / firemen / EMTs that they are today. Amazing stuff. We all know how well Seattle has this down. Where are we now? In modern era of resuscitation. We understand and obtain statistical data. We understand now it's just not an annoying thing. I know Clark Tyson is in here, and he will tell you that this is a very important thing. This is what changes practice. This is how we get things done. Your paramedics and your EMTs, now more than ever, are understanding that what they document affects change, not only where they're working in their system, but across the country and across the globe. We now know our data means something. We improve airway and breathing management. We know we just don't hyperventilate. We don't high-five everybody when we get a tube in place. We manage the airway now. It's not all about just getting an ET tube every single time, senior medics in this room. We manage the airway. The primary thing is circulation. It's compressions. It all evolves around compressions. We expedite defibrillation with those compressions when we can. We educate the public and say, you need more AEDs. You can operate this machine too. And we introduce therapeutic hypothermia. Wherever you are, whether it be in EMS or inside the hospital, we know that it has productive properties to it. We install cardiac arrest systems of care. We understand what David Boyd was saying about trauma systems of care. The 70s and 80s, he said, you know what, this works a lot better if you're all in the same room and every department gets together. Patient outcomes will be wonderful. He stands back now and smiles and says, I'm so happy everybody's getting this systems of care thing now. That all equals buy-in from every provider here, every administrator, every leader, and that equals patient success. That equals a heart that comes back on. That equals somebody going back home to their husband, their wife, their children, their grandchildren. We're not just turning hearts back on so that they can be shut off in an ICU in a couple days. I'm not discounting that, because the value in a family member holding their loved one's hand as that machine gets shut off. I know there's a cost value tied to it, but it's still priceless. We understand that. We're not losing that part. What makes a cardiac arrest system of care? How does it work? I think this picture is excellent. It symbolizes a lot of things. We know there's a lot of work that has to be done to get this system to work. However, when I look at this, I think of cardiology in the middle. I think of neurology on top. On the bottom, I think of emergency medicine. I think when the three of them get together, along with the support of administrative leaders like Lisa Monk, like Claude Corbett, EMS leadership, great things come together. So if we're all able to sit in the same room and not worry about what our specialty is anymore and share it, patient outcomes will be fantastic. Why do we drive this now? Why now is this such a big deal? I show this slide time and time again. We now have wonderful machines that can measure how we're doing on humans. We've had all this data before from labs, dogs, cadavers, mannequins going flying down the road. And we all know a mannequin, doing compressions on a mannequin, we're not really going to have the same interaction. This is a simple slide. I know it's a little gray off to the left here, but off to the left there we can see those compressions seem to be organized. There's one big abrupt pause in the middle there, and it's probably going to be a breath. And then maybe or maybe not some return of spontaneous circulation. Somebody decides to get on the road. And this is real-time data, this entire arrest. 2320 to 2357. Well, we're on the road, we're on our way to the hospital, and look what happens. That CPR is gone. You might as well open up the back doors to that ambulance and pop that lock open and push them out the street. Be far more productive. So we now know CPR has to be in place for it to be effective. Here's the data, continuously, time and time again. We're able to measure it now in humans. So here's that data I'm referencing again. You can see it. You show this to a healthcare provider, they say, yeah, you got me. I am in that club where I did 300-400 compressions, and I sweat poured out my face, and I thought that was the right thing to do, just like you guys did. Now we know it wasn't the right thing to do. We can retool it, we can do this whole CPR, get these compressions down again, and do it right. NCOEMS has some key support pieces behind this, and I pulled this specifically from their sites. Your best chance of survival is quality compressions and defibrillation. Don't worry about the airway right off the bat in witness cardiac arrest. Even the state agency, our wonderful Office of EMS and all of their leadership is behind this. They know that hyperventilation and hypoventilation is bad. It increases thoracic pressure, pulls down on preload. Every EMT out there is learning that. Every paramedic is learning that. It's airway management. It's how are you doing it. Everything focuses around the heart. What you just saw here is a wonderful, organized piece that we have actively going on in New Hanover County right now. 708 providers are now clicking in the same direction. A lot of you in this room realize that that's a hard thing to do. We trained, we researched over a year, we reached out to the big agencies across the country, we reached out to the agencies in the state of North Carolina, the systems that have already been doing organized cardiac arrest, and found that they were willing to share everything. It only makes sense to go to them and say, hey, what doesn't work here? Because we'd rather not start with what doesn't work. And they said, absolutely, we'd rather you didn't either. That was a pain we don't want anybody to see have to go through. That's big. This is one big family. So what you saw is a special dispatch in our county. What will happen is, immediately, all the doors will open up and everybody gets dispatched at once. We want 3 paramedics on this team to work with at least 3 firefighter EMTs. So they all go at first, they all go at once. This picture on the bottom here, that should look familiar to you, right? That's in a hospital. Same thing probably takes place when they have a code take place there, right? So they send out that code blue, you get that same response going on in the hospital. So here they come. Same thing. Location. Our policies and practices, you have to be safe still. Obviously still, or up in that area, there were people shot. There was a cardiac arrest going on there. We need to move that cardiac arrest around the corner. We don't expect them to work that cardiac arrest literally everywhere you find it. You have to use some judgment calls. These 2 places look familiar. That looks like a hospital waiting area. Definitely not an emergency room, right? To the left, it's empty. To the right, we have a patient room. Again, I think these same practices probably could be done here inside the hospital, as well as out in the street. If it works well out there, it's going to work well anywhere. Inside buildings, inside hospitals. Moving truck. CPR is only 19% effective when we're moving. We know that. We have data to support that now. If you're in a moving truck, A, the compressions are not good. If you're already coming out only a third of what the heart normally is going to do in the first place, right? B, it's not safe. If you're doing compressions in the back of the truck, I want you to remember this picture right here, because that's what you're doing. Unless you're risking life and limb and can't do it, stop that truck. Resuscitation efforts should be done on scene. Oh, another familiar scene. People rushing down the hallway, trying to do compressions, heading to somewhere else where it's going to be a benefit, losing 2-3 minutes possibly. Location you call for your team. If you're transporting your patient and they go from pretty bad to really bad and go into cardiac arrest, stop. Call for your team. Get everybody there. This is your patient's best chance. We'll call on the radio. We'll say, please send us an engine. We've got a cardiac arrest. Boom. That third paramedic will be dispatched, and an engine company will be coming with 3 people. We will work that cardiac arrest in the back of that truck and give that patient the best possible outcome. I think you can do the same thing inside of a hospital. Stop, hit the button, call for your team. Your team of organized providers. Everybody needs to know their role. Location again. I know I sound like a real estate agent over and over and over. It's a judgment call again. To the left, we're in a beach community. We had to make some adaptations. This is not an ideal place to work a cardiac arrest, right? That's a lot of people. Nor, we call our arrests in the field. I do not think this beach community would care for it too much if we call the arrest in the field, put a blanket over the patient, who's now a cadaver, and left. So sometimes we have to reach that and get moving. Judge Judy. Young man, young woman, you knew better. We don't do that. It's okay. Our EMS crews know that this is just a judgment call on scene. If they have to move, they have to move. Nobody is going to tell them, hey, you did the wrong thing. That patient's output was horrible because you were moving. They understand. There's no repercussions with this. You do the best you can. We reached the moment of termination of efforts. I know that those of you in this room who are not familiar with this picture as far as your patients go, maybe you have had to deal with it with a loved one. We have found that once a family member or even the public witnesses everything, and it's continuously explained to them that we're doing the best for them, compressions are optimal right here. We're bringing the emergency room to these folks. They have a better acceptance of this whole process. You saw how we're dealing with the son here. There's a pushback. It's very stressful for them. It's very stressful for that team leader who's in that role as well. This is tough, but we're finding out that 3-4 months later, the commentary coming from these families is how fantastic of a job they did. They truly did. And did you know that they have defibrillators? Did you know they have all these drugs? They did everything that they could for him. They repeat everything. And it helps that death and dying process begin. No more shutting the doors and keeping them out in the waiting room, and a physician comes out and has to give them the good news. We can start it here in the house. I know it's terrible to think that my loved one died in the house, but if you see all that take place, the best effort was made. Humans trying to do good things for other humans. I can't think of a better closure moment than that. Why we chose this process and an introduction to this PICC process? Well, it's called PICC Crew. We don't own it. We love the name, though. It goes well in North Carolina. It goes well in the South. It's a snappy little thing, the PICC Crew process. It is a combination of many organizations across the country. It was born in Texas, evolved in Florida. Ideas were taken from Seattle. Wake County took ideas from it. We took ideas from Wake County. We took ideas from Seattle, and so on and so on and so on. But we kept the snappy name, the PICC Crew process. Clinical indications, your patient should be in cardiac arrest. Contraindications, it doesn't really work so well with somebody under 1 year of age. And then your scenario, your area. Those of you who are sitting here thinking, I could never do this in the house, try doing it on this stage. I thought at first when I came in here, I was like, wow, this is going to be tight. And I thought, nope, this is an excellent representation of what a trailer would be like. We have trailers in New Hanover County. Do you? You can work a cardiac arrest in a trailer. This is about the size of a small modular trailer. We focus on minimally interrupted compressions. We pre-charge the monitor. Compressions only stop for less than 10 seconds. That's our goal. We don't want them more than 10 seconds. We want it under 10 seconds. We understand cerebral pressure. Our EMTs understand that this is huge. Our paramedics understand that this is huge. They understand that we need to keep that pressure up, and any drop in decline is going to be hard work to get it back up, and while we're going back up, millions of brain cells are dying. Infants and small children may require modification again to the size. This procedure is based on a 3-person team. You're not always going to have these resources. You can actually start with one if you think about it. The most important thing is compressions. Here it is laid out. Everybody has a role. Everybody understands this. This is what all 708 providers visualize in their head. They understand this. They understand who's on airway, who's on the defibrillation area, who's giving medications, who's the team leader, who's the support. This is everything that you just saw here on this stage. Your first arriving providers, position 1, 2, and 3, you notice that they weren't so worried about the airway right out of the gate. They took over compressions, established their SIG, made a work area because they knew there are other support services coming around them, and began. These crews assign these roles in the morning before their shift. They execute this consistently at their stations. They battle over who's going to do this stuff. They are proud to be recognized that they are part of this team here. They don't own this team, though. This is one big team. If we have to get it into compressions, then you're going to step into new compressions. Nobody exempt from it. We'll go out and get a housekeeper and have them do compressions if we need to. 2-minute rotations. No more 2-minute. No more hero doing 400 or 500 compressions. That doesn't work. We know that. We have to retool everybody's mind. Position 1 off to the left, located on the patient's right side. This person is accessing with an IO gun. Did you notice that? We don't come into this chest area. We don't interfere when you're doing compressions. And you have somebody come in on the peripheral side, you're apt to do what? You're apt to lead. That is going to take away from adequate compressions. This triangle does not get disturbed. You picture 3 pit bulls sitting there, and you better have a good reason to come in there and interfere with those compressions. It's easy to not forget to go in there then. Right, Nick? Pit bulls? Position 2, this is the code commander. This is the person that's, I'm sorry, position 2 is the AED. They're gonna put the AED on, and they don't turn the AED on immediately. Compressions have to go through. We want 200 to 400 is the range. Again, this isn't permanent. It's semi-permeable. We can make adaptations. But they don't turn that AED on right out of the gate. They position it. They go around the compressor. He or she knows that those pads are coming in, and they're staring straight at their hands and not allowing them to be disturbed. 3 is at the head. They're doing airway, and they're doing it after everything else is established with compressions. A king airway is what we use. A biad airway, a blind insertion airway device. Innovation will affect compressions. We know this. You might have a good shot at getting it with bouncing around and looking in there, but those of you that have been around there long enough, you know you're going to be very inclined to say stop compressions when you're looking in there because it's going to get aggravated and you know how important that is to get that too. Put the king in. We'll change it out later with an advanced airway. In that truck on the way to the hospital, they're going to make sure his pressure is stable. They're going to continue watching those 12 days to see how his current MI is doing, and they're going to change that king out. They're going to put an ET tube in. We know that that's still the best airway later on for them, but initially for the cardiac arrest, not necessarily. We manage the airway. It's not all about getting the ET tube right out of the gate. Position 4 gathers information, deals with family or public. This person should be heavy-shouldered. You got to be able to take, and you got to be able to teach and educate in simple terms. This person can be a battalion chief, regular firefighter, a regular paramedic. Anybody who's got life experience and understands this process can fill this role. A check sheet. You saw that check sheet go back and forth. Why would it make any sense to get on an airplane if that pilot's not going to do a pre-flight check sheet for every single flight? I know you've heard that before by somebody, maybe up in these parts, Wake County. Why would you do that to your patient? We're human. You can forget things. Check your check sheet. Produce one. It's okay. Position 5, the IO access that I mentioned before. 6, code commander. Comes in, hooks up into the AED, leads the down, the team leader leads the team, and the team works together. The code commander dictates everything as far as algorithms with the support of the person that's drawing the drugs on the IO. They work together in a team. The code commander is paying attention to CO2 levels, verifying that that airway is working, and is ordering up either the next shock by pre-charging that monitor and getting ready. That compressor at 200 is going to lift up. If it's shockable, he's going to fire. There's no more, are you clear? Am I clear? Everybody's running out the door to get away as cerebral pressure is going. Nope. We're going to fire that shock off. The next compressor is ready. It's going to get right back on the chest. regardless of a change they may see on the monitor, because we know if we don't do that, we get so excited, you get electrical and mechanical, they come back together for a second, and then because you move too fast, you're checking for a pulse, go back to compression for at least 2 solid minutes and try and keep those two together. It's that simple. If you get rosy, you stop. Don't throw them on the stretcher. You saw a lot of things done. We need to see if there's an MI here. We need to get a catheterization team up and moving at 1 o'clock in the morning. I used to say that 25% of these cardiac arrests were STEMI. I think now it's heading towards 50%. Are probably going to be MI in origin. So we need to get that 12 lead. We need to get 5 minutes worth of prep time in. Secure all your lines. Don't rip them out. We lose an airway, we're not managing that airway. Preload is going to be affected if you lose the tube. This is a fragile egg, which is now entering into a mobile coronary care unit. And this entire team knows that. They want to high-five each other and say, great job, but they know their battle is halfway there. They are part of a system of care that has just begun its beginning phases. And they will carry this fractured egg delicately to the emergency room. Here's our protocol. We worked on it for a long time. We're a hospital-based EMS system, and we're very proud of that. We have access to a lot of resources inside. We had plenty of meetings with neurology, plenty of meetings with cardiology, plenty of meetings with our stroke and STEMI systems, and now cardiac arrest systems care manager. And we tried to come up with what's going to work best outside of all the data that we brought in nationally. And we came up with some extra things on our protocol. We have coolers on all of our trucks. We got the money donated from our hospital foundation. Made a presentation, explained to them why, got the support from key leadership inside the hospital. Outside EMS agencies can do this too. You just have to be a little assertive and look for your leaders inside the hospital. I can promise you, they are not going to shut you out. Why do we engineer the process? Because we create uniformity. You saw it. There's less chance for errors. Accurate assessment of outcomes can be done now. As QA, QI, and everybody looking back, we're not necessarily armchair quarterbacking gibberish. It makes sense now because we know what was taking place in the house. There's always going to be room for improvement. There's things that are great that happen that we won't catch if we don't keep track of this stuff and we don't have assigned duties and tasks. It's the baseline for future modification. Like I said, this is semi-permeable. We can change this. We're constantly listening to everybody that's involved in this cardiac arrest. We know that we're going to have to change these things to our area. And we're going to share that data with any other system that was like us, that wants to put stuff together and get better with their cardiac arrest care. We're part of that team now of leadership, and we understand that. Our data and our results, since we put all this together, April 1st is when we actually began our true organized cardiac arrest systems of care. You see that line? It's very small on top. Yes, we've doubled our cardiac arrest. We've made race cars happen. That line is very small. What we've realized is symbolized by this picture. And this picture reflects generations and ages. If you look back at our data right now, the big thing that sticks out is that any one of these folks in this picture, and no, I'm not related to any one of them, could be affected by cardiac arrest. As you can see, there's many ages. We had a 33-year-old who collapsed and went into ventricular fibrillation and had no prior heart condition that is now walking. We have a 55-year-old who collapsed and went into VFib, who had no cardiac history and now is walking and back with his family. We have a 68-year-old who had some minor cardiac history, who is now back with his wife, Rose, thanks to Rose doing compressions guided by our CPR, or by our dispatcher, thank you. And a young couple coming along down the road watching Rose have a hard time with compressions. They got out and they helped. And we have a 78-year-old. A 78-year-old who is back living independently with her husband. It was her husband who started compressions on her after he learned CPR in their community 2 years before that. So I say to you, that data says to me that it doesn't matter how old you are, it doesn't matter if you have coronary issues. You can go into cardiac arrest any age, any time. And that's what sticks out. And that's an organized system of care that enables everybody in this picture to have a chance. I know time and time again, we've been asked by the American Heart Association, we've been asked by all these great leaders, come here, do it this way, come here, do it that way. Renew your ACLS card, renew this, renew your, we've got a slightly better way. We've changed page 128, 2 words. You need to get renewed. Okay, I'm part of that too, but it's different now. In the last 5 years, good data has come forth. There is another leader sitting on that horse. I know you guys know who that is. That's William Wallace. Picture William Wallace being data-driven medicine. We're all clinicians in this room. We're all clinical leaders in this room. We all have a chance to get on that horse and motivate the troops. I quote Brent Myers on GEMS magazine, as he says, I think the greatest accomplishment is the recognition that resuscitation of the out-of-hospital cardiac arrest is owned by EMS. That's because we've been doing it a long time out in the field. We didn't even necessarily have it right though, but we're retooling it. And we're willing to share how this is working out in the field with those of you that work on the inside of healthcare facilities as well. My conclusion, I know that every single one of you in this room are cardiac masters, cardiac arrest masters. You've done it for so many years. You know this is the way things need to be done. Put data in front of you and saying, this is how you should do it, organize your care. This is the right way to do it. You're going, yep, I see the evidence. My support, how I know that? This guy right here, Yoda. Either do or do not. There is no try. We need to all get together and work on cardiac arrest. Thank you. My references.